Hello, this is Kiali from Interview News Today, reporting from the Human Rights in Childbirth Conference in Mumbai. We have with us Aravinda of Ask Amma, Neha Chopra, Sohini, journalist, and Dr. Neil Shah. We are here with Aravinda of Ask Amma and Dr. Neil Shah, obstetrician at Beth Israel Hospital and assistant professor at Harvard Medical School and researcher at Ariadne Labs.
Got it all.
Hi, Neil.
Hi.
So nice to see you at the Human Rights in India conference. Yesterday, in your talk, you said that you found in your research that in the matter of maternal and child health, the hospital could be a risk factor. Could you share with our Ask Amma viewers, what do you mean by that?
Yeah, sure. So it looks like the number one risk factor for getting a C-section, at least, and possibly other outcomes in childbirth, is not a woman's preferences or medical risks, but literally which door she walks through. C-section rates in particular seem to vary between 5% and 90% by hospital in India.
This is what you found through your research?
That was the starting place for my research, actually. So, I noticed that C-section rates have gone up by 500% in the U.S. over one generation of moms. And none of the explanations for why this is happening seem to bear out. A lot of people think that it's because women are older than they used to be, there's more obesity, there's more, other diseases out there. That explains very little of it. I think that maybe women prefer to have more C-sections, but that doesn't explain it. So this was like this big mystery to me, and I wasn't really sure what we can do to make things better. But the opportunity is that some hospitals have figured it out. Other hospitals haven't.
So what have the hospitals
Well, that's the whole
done?
question. The work that I'm doing isn't rocket science. It's looking at the hospitals that are able to have appropriately low C-section rates for low-risk moms, and then looking at the hospitals that have really high C-section rates for low-risk moms and trying to figure out what's different about them. And among those differences, what are the things that we can generalize to help everybody improve?
So what can a woman who is expecting to become a mother, how can she understand this risk? How can she understand what is the risk factor of this hospital versus this hospital?
That's really hard. I think, I'm not sure how much agency many women have and how much choice they may have in where they go. Often there are a lot of things that determine where people go. From their own social networks to what is affordable and a lot of other factors. But I do think that there is an opportunity for women to at least ask the questions.
What questions should a woman ask?
Well, I think if they are a healthy, new mom, as most new moms are, they can make it clear that they're hoping to have a normal delivery if that's what they're looking for, and start a conversation with their provider to assess their risks as they go along, but hopefully if everything remains normal, try to keep normal.
So I think, if women learn that, a certain kind of diet will reduce your risk, they'll try to follow that. If they learn about certain exercises, breathing, yoga, good music, women are willing to make the effort to do all of those things. Now, if a woman goes and tries to ask a doctor, what is the risk factor associated with your hospital, how can that conversation
That's
even
a much
happen?
tougher conversation, yeah. I think you're right. Pregnant moms are very discerning about their choices. They'll give up food that they used to love because they're pregnant. They make big sacrifices, But yeah, there's something that's hard in that power dynamic that makes talking to their doctors different.
Have you had these kind of conversations with pregnant moms?
I have. I try to be intentional about doing it. In some cases, my patients will ask me outright, and in other cases, you have to start the conversation. But I think it's possible to have a conversation that doesn't feel adversarial. I think most people hesitate because they feel like they don't want to offend their doctor or their midwife or whoever their provider happens to be. But I think there's a way of having the conversation where you just sort of anchor the conversation around what you're hoping for.
We have a lot of birds
chirping,
so if you can speak up.
Sure.
I was wondering, how many doctors are like you that recognize the importance of these conversations, that see themselves more as providing more than simply survival.
Right.
In the sense of safe birth is more than just where the mother and baby survive.
I'll tell you, I think that most doctors want to do the right thing, and they truly care about their patients, but I don't think that as a profession we've done a good job of really recognizing that there are goals beyond just having an alive mom and baby. That people have goals other than being alive, believe it or not.
Right,
Yeah.
right. So in this conference, for example, we're hearing a lot about all of the intangibles and all of the compassion and care and respect and dignity. Most of the time, those words are associated with midwives rather than doctors. And what do you think should be the relationship among the doctors and midwives?
I mean, again, there's a rift in the professions where midwives are supposed to be on one side and doctors are supposed to be on the other, and it certainly doesn't have to be that way. I mentioned yesterday that it's considered to be a compliment as an obstetrician if you practice like a midwife. That being said, we're not midwives, we're surgeons.
Right.
We train to be surgeons, and there's a different kind of person who wants to do that. You're fundamentally impatient. Whereas like normal labor requires patience. I think midwifery is its own skill set, it's its own art form, and there's certainly a tremendous opportunity to have both types of providers available. The trick is to figure out how to best integrate them and to do that handoff when it's appropriate.
So one question which I didn't get to ask during the panel, which you just moderated, there was a woman who was talking about how, especially in India, there are many communities in which midwives are still practicing. It is a living tradition, not something that has been rediscovered or renewed. And she pleaded with us, don't do the way we did in Australia, where the midwife community was simply orphaned and now had to be reintegrated into society. Recognize the value of your midwives and incorporate them into the system. Now my question to you is, given what the system is, why would a midwife want to be incorporated into it?
That's fair enough. I mean, I think you'd have to design a system that accommodates the differences between where they're starting from and where we are now. I mean, it seems like most of the existing system doesn't have the capacity. One thing that we heard during the conference is that there's been a bunch of incentives put in place to try to get women to go to institutions, and those institutions aren't great. And it's not because the people aren't great or they're not well-intentioned, but they just don't have the capacity to deliver good care. And it's so stark that the outcomes are no different. At the same time, there's a tremendous access to care problem. So it seems to me that if you've got a lot of people who are ready and willing to provide that care, they can do it more affordably, and they're doing it equally safely, that we ought to use them. I think that this is probably, people have been talking about this conference as maybe a historic occasion and a turning point here, where we've had a lot of high-level stakeholders that have made public commitments in the room, and maybe this is the start of something.
Right.
Yeah.
Do you think there's anything to be said not only for allowing midwives to be integrated into the system, but perhaps the system to integrate itself into the world of where the midwives are currently thriving, which is typically a world which is considered undeveloped, primitive. These are the communities that are facing the brunt of today's development paradigm. Land is being acquired for so-called progress. All of those things are going on, and the first and worst affected are actually the communities where the midwife tradition is living. Do you see any relationship between this?
That's a good and very complicated question. I don't think I'm going to answer it well, but
Go ahead.
Certainly, midwives are practicing at the periphery of the existing system, and they ought to be practicing at the very center of it. I think that's good. Even in rural, under-resourced settings, and not even in particularly in those settings.
Earlier you had talked about a petition that would help women know more about the risk factors associated with different places. Can you tell something?
Well, I learned that there's a change.org petition that is sort of born out of this conference. It has nearly 100,000 signatures to get all of the Indian facilities to report their C-section rates publicly. I think that's a good thing. It's a good start anyway.
Is there any such requirement in U.S. hospitals?
There is now. So it's not a hard requirement. So all hospitals have to report their C-section rates to an accreditation body, but they don't necessarily have to make it public. But there are a bunch of public watch groups that ask them to, and patients are starting to demand it. So I think we're just at the cusp of something where there's starting to be a little bit more transparency around these things.
So I suppose if a patient asked for that information and the hospital wasn't willing to give it,
it wouldn't look great.
Right.
Right? Yeah.
I think Kiali also had a question to ask about your research lab.
Oh.
Yes. Why is it called Ariadne?
That's a good question. So the credit for the name goes to Atul Gawande. It's not me. But Ariadne was a Greek goddess who guided Theseus out of the Minotaur's labyrinth. So the idea is that healthcare has gotten really complex, and that we need simple solutions to help people navigate the complexity of the healthcare system, which is what Ariadne did.
That's what I thought.
Oh yeah, did you know the answer?
That's what I thought it was.
That's our hypothesis.
You're very scholarly.
Thank you.
Well, it's been a pleasure talking with you today.
Likewise.
Yeah. Good luck with your work.
Thank you so much. A pleasure to meet you as well.
Pleasure to meet you too.